What current standard of care in your specialty drives you crazy? Let's take a look at what Reddit says. Muttering some form of suicidal ideation automatically places one-to-one and psych evaluation regardless of context. Self-story. Was hospitalized during pregnancy for complications. I said, I don't want to be here to a nurse because I didn't want to be in the hospital. It was going to be a long stay, LOL. Immediate one-to-one for a week. Suicidal ideation all over my chart. Psych eval, social work, etc., etc., etc. I chose to read that as electroconvulsive therapy instead of etc. That's because they spelled etc. wrong. So, man, if they just started ECTing this person out the wazoo, that's definitely kind of overreaction to what she was saying. Common sense needs to be applied. As a combined specialty physician, a lot of psych consults for SI could be prevented with a follow-up question that my non-psych colleagues don't bother asking, such as, what do you mean when you say you don't want to be here? I try to teach my non-psych colleagues this, especially because when you call a psych consult, they are going to ask about the context. Would you call a pulm consult without some preliminary info on respiratory status in context of their chief complaint? It also doesn't help that we have a bunch of dramatic phrases in everyday life like, just kill me now, and I would rather die, etc. It confuses and scares some people afraid of liability or less familiar with such expressions. Calling a psych consult for CYA purposes is another one of those habits you repeat based on observation of those who trained you. Knee-jerk reaction without critical thought. The number of times I've walked into a patient's room when they were A, not expecting a psych consult, B, are in pain or otherwise don't want to have another person coming in to ask a bunch of questions, C, realize it happened because they never had a chance to explain themselves because their primary team didn't bother to ask. It ends up eroding trust between the patient and their primary team, which I then try to smooth over. Everything is defensive medicine due to the sheer chance of being sued. I'm writing notes for lawyers, not other doctors. C-collars, a medieval torture device for nursing home residents and drunk college students alike. Excellent for causing neck pain while providing little to no legitimate spinal protection. Holding metformin while inpatient. Reading the things we do for no reason article on this fully radicalized me. And yeah, I've known about this data on it being safe to continue metformin in the hospital. And I've been waiting for resuming metformin in the hospital to become more of a thing. But, over the past 4 years, I really haven't noticed any big change. So part of me wonders if, we should just start doing it. Like if I should be starting to do it more, because I still hold metformin in everybody because it's kind of the culture here. Curious to hear what you guys think about this one, because I did some reading about this back in the day, in 2020 or so, and I made the prediction that I think people are going to be using more metformin in the hospital. But it's been 4 years now, and really we haven't seen much change at all. You can see some pros and cons on both sides. Then this person says, unless it's a long stay, continuing metformin won't likely help the patient very much. I stop it because it's one less factor to consider in your initial workup, and maybe resume it when the patient approaches discharge. What's the benefit of metformin for a short inpatient stay? And then this person says, what's the benefit of continuing a number of other home meds over a short hospital course? Things can change very quickly. Little to zero harm in holding and zero benefit in continuing it in acute hospital stays. And this person says, yeah, I never continue it. It's one of those years to decades to see impact kind of medications that can potentially complicate a hospitalization acutely. Sepsis protocol for inpatients causes nurses to draw lactates for irrelevant lab/vital sign abnormalities without my okay, and wastes massive amounts of nurse and physician resources without improving outcomes. And I totally agree with this one. We have the same kind of sepsis protocol in our hospital, and I'm sure there's been some research on, it does catch sepsis at times, but from our standpoint, it really is just like patients getting poked and drawn random labs all the time when it's not really clinically indicated, just because their heart rate went to like 102 because they stood up real quick right before getting their blood pressure checked or something. So I don't know. I'd have to know what the data is on doing these sepsis protocols, but at least from our perspective, I think the big thing is we just see a lot of wasteful labs, irrelevant lab values being drawn when really it's not indicated. The fact that paroxetine is considered first line for numerous psychiatric conditions, despite being a garbage drug. And yeah, I remember making some notes on Paxil, and I think, one of the side effects of it is that it has the highest sedation out of all of antidepressants. So yeah, side effect associated with Paxil, sedation, has a higher risk of sexual side effects and higher risk of withdrawal compared to the other SSRIs. Not specific to a single specialty, but strictly adhering to protocols and guidelines without considering the person behind the diagnosis. Yes, that kidney lesion meets all criteria for a biopsy, but we probably won't cut out the kidney of a 90-year-old guy who is barely hanging on without dialysis, has around 30% of his lungs working, and his heart is only barely able to pump enough blood through all the clotted arteries. Just let him go home. Denervating medial branches of 30-year-olds. Pretending like injecting steroid repeatedly into a joint has better evidence than using orthobiologics, punching through pedicles for a basivertebral nerve ablation, or fusing two spinous processes together only, and pretending there is no long-term impact on biomechanics and structural stability of the spine. Wow, that was a lot of information that I totally did not understand at all. So really it goes to show you how much different some of the other specialties are from us. CPR/intubation being the default code status for everyone unless there's some sort of pulsed form. The Europeans have it figured out way better than we do, since it's culturally accepted that the physician gets to determine whether ACLS is offered rather than family. And yeah, I think this is something that would be probably really beneficial in our situation. Think about how many times we have to go in and clarify the code status, and then patient and family is confused, or other times that, is really a futile situation, and yet they still insist on CPR and intubation being done if the patient codes. I feel like a lot of excess stress, a lot of excess healthcare expenditures, and a lot of excess pain for the patients who are kept prolonged intubated on a mechanical ventilator when there's no chance of recovery. That's a lot of things that could be avoidable if physicians were able to just make the code status decision. But I think in the US, of course, this would be a very, very difficult thing to happen. I think culturally, Europe is much different than the United States. And so I don't think I would see this ever changing anytime soon. Legally, if two docs say resuscitation would be futile, we can make them DNR, but this rarely actually happens. I've had 2 attendings with the stones to do it, and it was effing awesome. I've done it. Very advanced age, demented, cachectic, septic shock from recurrent aspiration pneumonia. I brought another attending in and asked him to sign as well. Took one look at the patient and done. Can docs in the US not do this? You can, but there are risks. Specifically, the family suing you because you chose not to. They may not win, but who wants to get sued for doing the right thing? Freaking temporal artery biopsies. Let's go ahead and subject the little old lady to invasive surgery and anesthesia for a low sensitivity procedure for which we are just going to continue steroids regardless of the outcome. Plus, they are miserable procedures. Yeah, I'd love to know what the data is actually on obtaining temporal artery biopsy for evaluation of giant cell arteritis. I actually have a family member recently who received a presumptive diagnosis of giant cell arteritis, and they did not get a biopsy and just started on steroids. So I wonder, if you have all the classic signs and symptoms, how important is it to actually histologically confirm the diagnosis? Agree on this: ultrasound vastly underutilized too, could likely save many from a biopsy. Clinical syndrome plus positive halo sign, just treat it. Radiologist here, feel free to skip the halo sign while you're at it. If you're going to treat it, just treat it. Well, this person says, if we were going to subject that little old lady to a year of steroids plus or minus biologic, we want to be damn sure it's the right diagnosis. That's a very convincing argument. Countless times someone has been diagnosed with GCA without biopsy and has a non-specific headache 3 to 4 years later, and you always wonder if it was even the correct diagnosis in the first place. Yeah, this is actually a very convincing argument. No one wants to be sued if they lose vision, so we have a low threshold to start steroids initially, but with a negative biopsy and depending on their clinical features, we taper steroids pretty quickly if the biopsy is negative, and less likely to start biologic if the biopsy is negative, so it does change our management. The difference could be a few weeks of steroids with a quick taper versus a year of treatment. Biopsy takes 15 minutes and can be done in minor room under local. I hate doing them because it's time consuming, conversation with the patient, and pays terribly. That being said, it's still the gold standard and needs to be done if suspicious. Agree that it helps more with low suspicion cases. High suspicious can do bilateral biopsy or just treat. If y'all would stop ordering ESR and CRP on every 80-year-old with a headache, we would not have to do so many LOL. Piece of shiz procedure. I did my senior talk on this as an optho PGY4. We looked at 25 years of data at a big academic center, a few hundred GCA cases that were diagnosed and treated with high-dose prednisone. Biopsy was positive in 20%. WTF is that trash? Jaw claudication and simply age were more useful and predictive. So yeah, I guess in this case, those 80% of people who were not positive on the biopsy, the rheumatologist may kind of look at the whole clinical picture and the clinical scenario and be more inclined to trialing a taper, which could be potentially one of the benefits of getting that procedure done. Insurance that makes us try so many cheap migraine drugs, anti-seizure, antidepressants, and beta blockers before they will cover the CGR stuff that actually targets migraine pathology and works really well with fewer side effects. So I just did a video on this one. You can check out my buprenorphine for medication-assisted treatment video, but if naltrexone extended release for opioid use disorder doesn't decrease mortality, and both buprenorphine and methadone do, help me understand why naltrexone extended release is still considered a first-line medication. Well, based on my reading of it, it did seem like there was some preliminary data, or at least some data, that did also improve outcomes and decrease mortality. But obviously the data wasn't as robust, and so that's why buprenorphine and methadone are appropriately more favored. But anyways, easy. Prescribing opioids, super duper scary. Prescribing not opioids, less scary. And while we're at it, my personal pet peeve, at least if I were to practice in the US, is y'all's general ambivalence towards the spike in pain patient suicides after the pendulum swung to the other side hard with those draconian MME limits, etc. Thank you. People in pain are paying the price for addict behavior, and there's no decrease in addiction and an increase in addict overdoses. I think this is a very interesting point. Really, I do think we are so strict with opioids these days. And that's just how we're taught to practice. And I think in some senses, it has been beneficial, right? We want to avoid escalating people's opioid medications to the middle of nowhere. But are there some side effects to how strict we are with giving opioids these days? And is that leading to more people seeking street drugs or illicit drugs instead, which are far more dangerous? It's definitely an interesting point. And I wonder in the coming years if this practice will change at all, or if we're going to have some more guidance on what we should do in this situation. Fasting labs at routine preventive exams. Fake and dumb. Yeah, I never asked for fasting labs. The only time is if you really want like a very accurate triglyceride level, which most of the time we're not even caring about the triglyceride level. So I basically tell them, lipid panel, you don't really need to fast for it. Oh, this conversation is talking about the exact same thing here. Using continuous fetal monitoring. Positive predictive power for cerebral palsy is 0.14%. This one will never go away, LMAO. Fetal monitoring is not used to detect cerebral palsy, it detects fetal distress. Either way, universal continuous fetal monitoring is more of a CYA practice than one rooted in evidence. Are you going to trust that if they don't run a continuous fetal monitor, your nurse will check fetal heart rate every 15 to 30 minutes? All right, so what standard of care things in your practice bother you guys the most? Let me know down in the comments below. And I think there were some very interesting topics here, and I'm curious to hear what you guys think. I always feel like with these Reddit posts, it's kind of for entertainment, but also you can learn a few things at the same time because people bring up these interesting points that you wouldn't have considered otherwise. So thanks again for watching. I'll see you in the next one, and peace.